Well, hello, everybody, and welcome to another DAYL Wellness CLE. We're so grateful to have you here today. My name is Jay Collins Spring. I'm one of the co-chairs of the Wellness Committee and the moderator for today's panel, which is focused on some very important and very timely topics relating to mental health and depression and suicide. We are joined today by an absolutely stellar panel. It is my pleasure to introduce Ms. Terry Bentley Hill. Terry is a criminal law practitioner and one of the leading attorney mental health advocates in the state of Texas. And of Ms. Kara Bradshaw. Ms. Kara Bradshaw is a licensed professional counselor where she practices at Room for Change, PLLC, right here in Dallas. So Terry and Kara, thank you so much for making the time to come and talk with us today about these important topics. We're so glad to have you
here.
So
glad to be here. Glad to be here. Thank you for asking us.
So I wanted to start off just by giving the audience a little bit of context about what we're here to talk about and why it matters. And so I pulled some statistics from a couple different reports that have been released in the past few years about depression in the legal profession, right? So there was a joint study of the California and DC Bar Associations 4 years ago that found that 1 in 2 practicing attorneys experience symptoms of depression and anxiety, right? Which is a staggering number. And then a similar number, over half of attorneys are estimated to exhibit risky drinking behavior, which correlates with depression. 1 in 4 female attorneys are contemplating leaving the profession altogether due to mental health struggles, including depression. And nearly 1 in 5 male attorneys are contemplating leaving the profession. We see that these are, and the reason that we wanted to do this through DAYL, the Dallas Association of Young Lawyers, is that we see that the newest attorneys are the ones that get hit the hardest. If your job title, according to a 2014 study from the American Bar Association, if your job title is junior associate, your risk of committing suicide increases by more than 2 times, as opposed to of counsel, a senior associate, or a partner. And attorneys under 30 are twice as likely to experience suicidal ideation. So this is an issue that is so important to our community, and it's particularly to our membership here in DAYL. And where, so Terry, I know that you have a very interesting story in the way that you found yourself coming to the attorney wellness work. Would you like to share that with our membership?
Yeah, sure. And hi, everybody. I'm so glad you decided to join us. It's such an important topic. In fact, I think it's the most important CLE you'll attend, period. I think that it is so important that we take care of ourselves so we can really be the best lawyers we can be. And I say that because I've experienced the fallout and the repercussions of not taking care of oneself. And specifically, my former husband was the elected district attorney in the Panhandle, and the stress of the job, the medicating of the anxiety, substance use disorder, alcoholism, and depression led him, first of all, because of the nature of his job, not to ask for help. And I was not an attorney at the time, and I did not ask for help either, because we were afraid it would ruin his career. And many lawyers are afraid to reach out because we're afraid it will ruin our career. And I'm going to tell you the other side of that. If you don't reach out and get help when you need it, it can take your life. It can not only take your job, it can take your family, and it can take your life. My former husband, almost 30 years ago, took his life in our home when our 4 daughters were sleeping. And then 9 years after that, my 14-year-old daughter, my youngest daughter, also took her life. And so this is a very personal topic for me because I know that we can, each one of us, learn techniques, what to look for, learn how to speak the language of depression so we can help ourselves and help others.
Thank you so much, Terry. And it's such a uh, it's such an important topic for us to acquaint ourselves, like you talked about, with the language of depression. But before we get into that, Tara, I'd love to get your insight on what depression is, right? Like we all kind of have this intuitive understanding of, what depression feels like or what it, but from a clinical standpoint, from your standpoint, what when somebody says depression, what are they talking about?
Sure. I think, we look at a number of different things. And, again, I want to start by saying, like, thank you for having me. And I'm really happy to be a part of this. But I think one of the things that we think about when we think about depression is we almost indirectly associate that with extreme sadness. And sometimes that might be the only thing that we see or the only thing that we understand it to be. But we experience it in different levels, sometimes internal, right? So depression may look like the type of thoughts that you're having, a lot of hopelessness, a lot of helplessness, a lot of fear. And so you find that that's kind of experience internal where you might not know how to verbalize it. You might not know how to identify what's kind of going on inside of you. A lot of the times you also will see kind of that external experience. And so you may have other people that notice this, or you may even see it in yourself where these are behaviors or changes or situations that you might find yourself in that are kind of like, what is happening? This is not an experience that I'm comfortable with. And that could look like changes in sleep. We might see increased sleep, we might see decreased sleep. It could look like changes in appetite. So you might see increase of appetite, but you also might see decrease of appetite. You'll see, isolation. So this might be a withdrawal into yourself, or if you're seeing it in somebody else, a withdrawal away from experiences or connection or people. It also might just be putting themselves in potentially dangerous situations. So there's a lot of internal things that we experience, and there's a lot of external things that we experience that are kind of show up, and they don't show up the same way for everybody. We have a criteria clinically that kind of helps us assess what official diagnosis, and I'm using just like air quotes because not everybody fits in the same diagnosis. It doesn't always look the same for everybody. But you might have a different diagnosis of major depressive disorder, and that diagnosis may be severe or it might be moderate. It might be persistent or it might be a one-time thing. You also might have a diagnosis of seasonal depression disorder, right? And so that might show up during the winter time specifically. Sometimes that shows up during the summer. Those are not specific, but we find that they might be more situational to our experiences. You also might find that your depression is experienced after a loss, right? So it might be more bereavement, which clinically we started to implement into our language and into our diagnoses as well. So, there are certain signs and symptoms that we kind of look for an official diagnosis, but you don't necessarily need that to understand that things might not be going well. You might not be feeling your best at this time.
So you mentioned these different types of depression. I'd love to kind of get into that a little bit. You mentioned that there's differences in persistence and differences in severity. So what are the sort of different the difference between the different severities of depression disorder?
Sure. So severity is really going to look like how many symptoms you express, right? So if you're kind of at that low severity, so the scaling for clinicians is mild, moderate to severe. Those are you're going to be severity scaling. So if you're showing 1 to 3 symptoms, you're kind of at a moderate level. It's distressing, it's impacting you, but we're not explicitly concerned. You can kind of work through this maybe, and we might address those specific symptoms that are coming up. Your moderate is going to be about your 3 to 5 level of symptoms. So if you're showing 3 to 5 of the listed depression symptoms, you're going to be labeled as like moderate, where severe is you're going to be up on the scale of like most, if not all, of the symptoms you're experiencing.
So Terry, you referred earlier in our conversation to the language of depression. Well,
Mhm.
what's the language of depression?
Well, like Karis mentioned, there are a couple of ways that people exhibit depression. And let me just say this. Oftentimes, you don't know you have a mental health issue until you don't. Okay. You know something's not right. You know something's, you can't put your finger on it. Something just doesn't feel right. You're not functioning at your highest level, but you don't know what to call it. So oftentimes, uh, our, our, our words may demonstrate the mental health issue, whether it's depression or anxiety. There are physical signs that we also experience. For example, the black and white thinking, the words, people will be better off without me. I'm a complete failure. I'm too stupid to be a lawyer. I have imposter syndrome. I'm not good enough. All of those messages that we're we give ourselves, and over time, if we do not do something to basically interrupt those thoughts, they can become persistent, and truly, then you might be able to see it in someone's actions. For example, you know, my former husband said some. He spoke the language of depression, and because I didn't, I missed it. And I'm not being mean to myself. I just didn't speak the language of depression. And my youngest daughter, she would tell me she has no friends, which I knew better than that. But that's what she thought. And that's what she was telling herself. And like Kara said, she was sleeping constantly. So she was showing signs both verbally and non-verbally. But I didn't know exactly what to do with that. And so I've had to learn the language of depression. And once I did, and once I know what to look for, it makes all the sense in the world, because my gut would tell me something's not right. I just didn't know what it was.
I think something that you mentioned there, and if I can take us kind of off script for just a second, I think something that you mentioned there is not beating yourself up for not knowing.
Right.
I about a year ago, I lost a good friend to depression and suicide, and looking back on it, the week or two leading up to it, red flags all over every text message, every phone call, but I wasn't attuned to it, so I wasn't picking up on it.
Right.
How can somebody work through those feelings of guilt that might arise when you have that experience?
Yeah, it is absolutely so true. Number one, you can't beat up on yourself. You're giving yourself responsibility that doesn't belong to you. Okay. So, and especially when you lose someone you care about, it feels very personal. Like you feel like you could have done something. There should have been something you should have done. What if I had done this, or what if I'd answered that text message, or how come I didn't answer the telephone? How come I didn't do all of these things? Well, the bottom line is that is putting way too much responsibility on your shoulders. But the point of this CLE, the point of this discussion is to say, hey, when we do see the red flags, when we do see the signs, there are things that we can do that might be able to help with a suicidal crisis, or the pressure that someone is feeling and building up, and it might be able to alleviate some of that pressure that person is feeling.
Kara, from a clinical standpoint, if you were trying to educate the layman of these are the things you should be looking for to see if someone in your community, a friend, a family member, a neighbor, a coworker is experiencing depression, what would those signs kind of be?
Sure. I think one of the biggest ones, and one of the more common, is isolation and withdrawal more than anything else. So you might find stepping back away from previous engagements that normally they would potentially be participating. You would find that they are maybe not responding to messages as much as they might have used to be, or that the connection is not as strong as it used to be. And so there's that piece of it, but then there's also like, as Terry has mentioned, a lot of the language behind it, right? Of like, I'm not feeling my best. And this is, you know, kind of one of those lower level things where we might have like that language of depression where someone feels very comfortable saying like, hey, I am not doing well. I am struggling. I am having a hard time. And they might be very forthright and outright with you on how they're experiencing things. And it is important to take people seriously when that's happening. But you might also find more subtleties and like, you know, things are just really difficult and I feel like I just can't get out of bed and I'm just not as hungry as I used to be, or I just can't find enjoyment in things, or, you know, people might be more tearful in the conversations, or they just might be more sad, or like not really seeing things for the future. So those are some kind of things that you might notice in other people, but it also is important to kind of notice in yourself. Like this CLE is really important. How do we spot this in anyone else? But it also is important to be able to kind of take inventory of like, how am I doing with some of this information? How is it sitting with me right now? And if it's sitting with you uncomfortably, that might be important to kind of sit and think about for a minute.
So are there any kind of tools that somebody can use? Like, let's say, because, you know, I think that's exactly right. And, you know, Terry, you mentioned this earlier as well, is that depression doesn't, you know, come in, knock on the door, let you know it's here. It sneaks up on. So
Mhm.
if you want to do that kind of self-analysis, self-reflection, are there any tools that you can use to help identify in yourself something that there is a problem that you're not aware of?
Sure. I think one of the biggest clues that I find that I hear from clients in particular that they're just like, something isn't just right, is that the things that used to bring them enjoyment are no longer bringing them enjoyment. And the people that they used to connect with, they're no longer seeking out those connections, or they're feeling uncomfortable with those connections, either because the vulnerability feels too strong and they don't want to open up and they're uncomfortable about where it might go, or it might just be more difficult to even get there because of how much weight they're holding. Those are kind of the two that I find that people take inventory initially on, of like, things that I like, I don't like as much anymore. And, you know, I'm just not as connecting with people anymore. I'm really choosing to like isolate and withdraw. And then you kind of might go and talk to a therapist, or you might talk to somebody else. And then the question's kind of, well, how's your eating? How's your sleeping? And then that kind of starts to like, oh, you know, I'm not getting as good sleep and I am just eating a lot more than I normally would be. And so sometimes you kind of need to start that conversation to start kind of taking other inventory.
Sure. Terry, in your experience, because I know that you have a long history with your foundation and with TLAP, and focusing on the way these issues specifically affect attorneys.
Mhm.
In your experience, how do these kind of depressive symptoms impact the practice of law?
That's a great question, Jay. And, you know, I know this is a CLE that's directed to younger lawyers. And you mentioned some statistics early on. And just to piggyback on that, the ABA did a study in 2015. It's old, but 2015, a study with 16,000 lawyers. And the results came back that if you're in your first 10 years of practice, your odds of becoming a problem drinker are 32%. And so there's definitely some medication for the anxiety and the stress that's going on. And many people medicate with alcohol or, you know, I don't know, whatever else. Okay. So the question is, and when I go into law schools and I talk to law students, I'll say, we prepare you for contracts. We prepare you for oil and gas. We prepare you for criminal law. We prepare you for procedure. We teach you all of those things, right? But we don't teach you and prepare you. We don't teach you how to take care of yourself as a lawyer. And our profession struggles more than any other profession with some of these mental health issues, depression, anxiety, etc., off the charts. Why? Think about it. We are wired in a certain way. We are very high achievers. We are perfectionists. Many people have gotten A's all through undergraduate. They get to law school and they compete against each other and they get a C, and it blows them away. All the negative self-talk begins. And then, of course, the number one thing is that we are an adversarial profession. It is important for me to know what your weaknesses are. It is important for my client for me to find the weaknesses in your case. We are battling each other. We are not working together. If you think about the medic, and you've got you're in an operating room, and you've got a surgeon, and you've got surgical nurses, and you've got staff and an anesthesiologist, they're all working together for a common goal, right? We're not that way. We are battling. And what that does is it takes a toll on us emotionally and physically and mentally and spiritually. It just takes a toll.
Absolutely. Absolutely. And sometimes to turn to sort of rip the Band-Aid off, I think what we've kind of been skirting around is when that toll racks up enough, we get to the point where we're dealing with suicide.
Right.
So I think I know, Terry, you have a foundation that you call Stop Minding Your Own Business.
Right.
Well, what's the work of that foundation, and why did you pick that name?
Well, thank you. It's a great question, and it's an important question. Just to give you some background, I do a lot of speaking about. I tell my story all the time because I believe that shame dies. And see, shame is associated with a whole lot of the mental health issues, the substance use disorders, et cetera, substance use, so much shame. And I believe that shame dies when stories are told in safe places. And I didn't write that. I found that makes total sense to me, because it's our stories that can unlock other people's hell, because they may be going through things, but when they hear someone else share their story, they'll go, oh, okay, I can relate to that. And then maybe I can get some help now because this person has led me to that thinking, basically. I was emceeing an event for a suicide foundation, a suicide awareness and prevention foundation. And I was emceeing in this event, and there was a young man speaking, and his name was Kevin Hines. And many of you all may know about Kevin Hines. But to make a very long story short, I wanted to know about him before I introduced him. And when he was 19 years old, he was suffering from undiagnosed bipolar disorder. And he was speaking the language of depression. My family would be better off without me. I'm miserable. I can't go on like this. I'll be better off dead. All of the language of depression. And so he decided to jump off the Golden Gate Bridge because he lived in San Francisco. And so when he got through and he jumped, and he survived the jump. And he's one of 43 people to ever survive jumping off the Golden Gate Bridge. So I could tell you this long story, and one of these days come to a CLE when I tell you the whole story. Well, I can tell you the whole story. But when he got through telling me, and believe me, he was talking to the mother of who lost a child by suicide. And I said, Kevin, what were you thinking when you jumped? And he said something I'll never forget. He said, Terry, oftentimes when a person decides to die by suicide, they'll make a pact with themselves. If this happens today, I won't die today. I may die tomorrow, but I won't die today. And the pact that he made with himself is if one person asks him, are you okay? He wouldn't jump. And he goes through his entire day of encountering people, and not one person saw a 19-year-old young man sobbing his eyes out all day long and standing at the rail of the bridge. No one asked him, are you okay? So he jumped. And when I talk to teenagers, I really emphasize this point, because he said the minute he jumped, he regretted it. The minute, I don't want to die. I don't want to die. So when he got through telling me his story, I thought, oh my gosh, we can all ask the question, are you okay? We've got to stop minding our own business. So that has been just like a battle cry. Stop minding your own business. We can ask the question when we see someone struggling, are you okay? And then we stop talking and we listen, because oftentimes people will, say, oh yeah, I'm fine, and you know they're not fine. So you ask the question again. I'm really concerned about you. I care about you. I'm coming from a place of concern and love, not judgment. So let's talk about it. And oftentimes people will open up. And when they do, it can relieve some of that stress because they're validated, their pain is validated. I remember going to a therapist after my former husband died, and after Hallie died, my daughter died. And I remember thinking, I'm crazy. I am going crazy. Grief, like Kara was talking about, grief is its own animal. But I felt like I was losing my mind. And for a therapist to say, no, you're not losing your mind. That's exactly the way you should feel when you've lost your child. It was like, oh my God, okay, good. All right, I'm going to be okay. I'm going to be okay today. So the whole point of the foundation is to share how to approach someone who is struggling. I never pass someone in the courthouse who's crying, and I work in the criminal courthouse. It's not a happy place. And I never pass someone who's crying without stopping and thinking of Kevin's words if one person had asked him. So I will ask them, are you okay? And it's so interesting to see their reaction. And I've done it with lawyers who are depressed, who are suicidal, who are now, because they were willing to share, have gotten the help that they need, and now their practice is thriving. But it's so important sometimes to do that reaching out and say, hey, I'm here for you. Here is my hand. I'm going to grab hold of you, and we're going to go through this together.
Absolutely, absolutely. And so Kara, I'd love to talk a little bit about the clinical side of suicide, right? So when you see a client and they're presenting with, and you think that the suicide might be a risk, what kind of things are they presenting with?
Sure. I think it is important to note that, suicide is to some degree somewhat of a spectrum, right? We might find that initial kind of experience, that suicidal ideation is what clinically it's called, but generally it's just suicidal thoughts. So the general thoughts of, I don't want to be here anymore, life is hopeless, life is helpless, that can kind of fall on a spectrum. And so clinically we kind of look at it that way, because there are some people who just have the thoughts and it doesn't go anywhere. It doesn't mean anything for them. It just kind of comes. We kind of call them like compulsive thoughts. So it's just, or intrusive thoughts, or it just might come and then it leaves. And it's like, ooh, that didn't really feel good. Right. And so I want to be clear in this, that like not every ideation or not every suicidal thought means you need to go to the hospital. You need to be taken care of. Right. Sometimes it just means I need to talk to somebody about this, or I might need to re-engage in certain things that might make me feel better, or I might need to find new hobbies and things like that. I might need to be disconnected from some of these things that don't feel well. So I want to start by saying that as like, because I'm going to get into like a little bit more clinical talk that isn't as enjoyable, but I want to start by saying, that not just because you have a thought doesn't mean you need the most extreme measures of clinical work to work through that, right?
We can kind of dive into that.
Yeah.
How do I tell, let's say that I'm experiencing intrusive thoughts.
Mm-hmm.
How do I tell when those thoughts become concerning? How do I tell when those thoughts, oh, maybe I need to go talk to somebody?
Sure. So persistence is the first one that comes to mind, right? If it's showing up more often and it's showing up like in multiple situations as opposed to maybe situational situations, you might find that it's like moving up on this scale of ideation. The other one is clarity, right? So those kind of lower things that kind of lower ideation of like, I just don't want to do this anymore, or I just kind of want to be done with this. That's a little bit lower on the scale. It's not very clear. That's a little bit more vague, right? That's not comfortable, but it's definitely a little bit vague. And as we kind of get into it of like, I don't want to be here anymore. People would be better off without me. I don't think I should live anymore, is like we're moving up the scale. Persistence and clarity in those thoughts are kind of some of the ones that I would take note of. The other thing that I would take note of, and I had it and then I just lost it. That's so helpful.
It happens to all of
Is
us.
the idea of like a plan. All right. So if I have a plan or if I have an intent to act on some of these thoughts, those are going to be things that I would be like, okay, it's getting worse. It's getting worse. The other thing, and I found it now, is if it's distressing. So if you are having these thoughts, and even honestly, even if it feels a little bit like intrusive, or even if it feels a bit compulsive, and you are distressed by this, go seek help. There's not really a timeline. There's not really any like specific moment that you need to be talking to somebody. Even if I'm sitting here saying like, it's not too bad until it hits this spot. That's irrelevant. If you are distressed by it, go talk to somebody. Like that's the end of it. Like if it is causing you discomfort, go ask somebody for help.
That makes perfect sense. So that makes perfect sense. And you talked about this kind of scale, starting with ideation, and then where do we grow to on that scale?
Sure. So ideation is like, you kind of start at like a 1 or a 0, right? So it's a little bit vague, and then you move into more like, I don't want to be here anymore. I don't want to do this anymore. You're kind of up on like your 9 and your 10s, that kind of thing. And if you start introducing kind of those plan thoughts, right? So I have a plan, I'm going to act on it. We also kind of scale that a little bit. So you might have a few plans or ideas of like, well, I could do this. Then I might ask, how likely are you to do that? And if it's at the bottom of the scale, it's like, I'm not really likely to do that. Okay, then we might need to work on kind of improving your self-esteem, improving your confidence, seeking into activities or hobbies that start kind of lowering the ideation. Or it could be like, I have a plan and I'm going to act on it. Right. And it's clear as day. Like, I don't want to do this anymore. I have a plan and I have full intent to do that. Then it's like, okay, you need a higher level of intervention. We need to be moving you in a direction where you are safe and as safe as you possibly can be.
And Kara, Jay, if you don't mind me asking Kara this question, Kara, isn't it true that it's a myth? When it used to be, well, I don't want to ask someone if they are thinking about harming themselves because I'm going to plant the idea in their brain.
Oh, yeah.
Well, it's a myth. You're not going to plant an idea. They will have the idea in their head already, but basically what you're doing is you're trying to diffuse the situation. Is that right, Kara?
Yeah. Yes. The more that we learn about this, the more that we know that, like, as you even mentioned earlier, shame is a big driving force of keeping a lot of these things hidden. We see shame in substance use, but we also see shame in depression, and we see shame around these thoughts. And so the more comfortable you are with saying like, hey, that's not comfortable, or I'm concerned about this, or that's kind of scary, or even from a clinical standpoint where I might be more upfront, it's like, it sounds like you are suicidal. You are removing that shame and saying, it's okay to feel this way. We don't want you to feel this way, but I understand why you do. And I want you to get better, and I care enough about you to get better. By communicating that and labeling it for what it is, you're able to kind of take away the secrecy, take away the fear of opening yourself up to that.
So now that we've kind of got our arms around what depression is, what suicidal ideation is, I'd love to talk about what we can do for people who are experiencing these kinds of experiences. So, there's a panoply of different types of mental health professionals, and it can be very opaque. Like, what's a what's a LPC? What's a psychiatrist? What's a psychologist? What's a life coach? No one needs a life coach ever, but what's a life coach? um, um, so how do we identify the right source of help for us? Once we said, I have depression, I need help. How do I identify where I go for that help?
Sure. I can take this part and kind of run with it if you'd like, Jay, but to kind of answer some of those questions, we have a number of different like labels here, right? So LPC, or a licensed professional counselor, is the primary license in the state of Texas. What that just means is someone who can practice clinical mental health work. You might see licensed marriage and family counselors. They do what I do. They just are hyper focused in like couples and families in particular, but they can also see individuals. So and then your licensed social workers, they're also going to be able to do what I do. They're just from a social work standpoint. They're not necessarily treated, their training is just a little bit different. So those are your primary kind of licenses in the state of Texas to treat clinical mental health. Psychiatrists are going to prescribe medication. They almost exclusively do that. I've never met a psychiatrist that sits down and has a therapy session and then prescribes medication. A lot of the time they're working hand in hand with your therapist, whatever license your therapist potentially has. Psychologists are usually more at the doctorate level. The only difference really between a LPC or a licensed therapist and a psychologist is that they can perform different type of screeners and assessments than I can, just because they can assess them. But for the most part, there's not a significant difference between those two, and they'll charge more because they have a doctorate. Those are the primary differences in those. When we're looking at our levels of care, so when we're looking at like severity versus levels of care, I think it's important to keep in mind that you can, if you are distressed, you can start anywhere. Like if it is concerning, anybody that you can talk to, you can start at any point, and someone will be able to refer you to the right level of care. So you do not need to know where you need to start. You just need to start with somebody. That is the first step. You just need to start with somebody. And if they are like, hey, this may be more severe, you need to go to this level, or this may be more severe, you need to go to the next level, then they can kind of walk you through what that looks like. But your role as a person who is struggling with this and wants to get better is to just start with somebody. That's it. And so the different levels would be an outpatient clinician like myself. That just means that I might see you on a week-to-week basis or a bi-weekly basis, and we just do therapy, either talk therapy or different modalities that might fit best for you. The next level would be a PHP or an IOP. That just means partial hospitalization or intensive outpatient care. Partial hospitalization is the one right now in Texas where adults are able to go to, because Texas is one of the worst states for mental health treatment in the country. We do not have residential mental health care in the state of Texas. We have residential substance abuse care. That is fine, but it's not really going to meet your needs if you're facing like severe depression that you can't necessarily get out of. So if you're needing a residential care, you might be referred to someplace out of state. Now, if you are in a moment of like you're high on all those scales, you have high ideation and you have a plan and you have an intent, the likelihood is you're probably going to be placed in a hospital setting of 72 hours to about 10 days, depending on the necessary needs, where they get your medication all situated and they kind of help manage your medication and kind of bring your levels back down a little bit. That is if we're really high on the severity scale. If we're a little bit lower, you might find yourself at a PHP or an IOP. PHP is like a day program essentially, and so you just go for a day and you do that for about 4 to 6 weeks, and then you might drop down to intensive outpatient, which is about 3 groups a week, and then that's another 4 to 6 weeks, and then you would drop back down to seeing a therapist once a week during that time. So that is the drop down, and then if we have to escalate, that's the scale back.
That's phenomenal information, and it's great to kind of have that sense of how the whole ecosystem of treatment works. I'd love to talk a little bit, Terry, about the roadblocks that we have in our legal culture to seeking treatment. I think that it can be so difficult to tell your employer, "Hey, I need this hour off to go meet with my therapist," or "I need to take time away to go to a hospitalization program." How can we overcome that roadblock?
Well, it's a change in the culture. It's a change in our thinking, which is slowly happening. The Titanic is slowly turning. We've got lawyers' assistance programs in all 50 states. The ABA is very focused on attorney wellness and is really encouraging law firms to change the culture in their law firms and to sign a wellness pledge and to have programs for their attorneys, et cetera. So that's the good news. But I want to share just a little story that I experienced, especially during the pandemic when we were all locked down. I got a phone call from this law firm in New York, and they said, we would like for you to speak to our associates. They are so stressed out, they don't even feel like they can get up and go to the bathroom. I thought, oh man, okay, yeah, sure. I'll be glad to talk to them. I'd love to. And so she wanted to know what I said. And so I went through my presentation with her, and then I got to some of the things that we can do for ourselves that can help with our mental health and our dealing with stress in the profession, et cetera. And one of them happened to be sleep. And I said, sleep is vitally important. We really need 8 to 9 hours of sleep because of the way our brain cycles. And she's like, well, you cannot talk about sleep because they can't get 8 to 9 hours of sleep and they will stress out over not being able to get 6, 8 to 9. And I'm like, oh, okay. Then I said, well, how about this? How about we're so connected to this thing? Why don't we just disconnect every now and then? And when we go to dinner with our loved ones, we put our phone down. I mean, she's like, you cannot tell them that. They will not be able to do that. And she said, and the partners are upset because the associates are complaining that they have to work 14 hours a day when the partners are saying, we had to work 16 hours a day. Big deal. And I thought to myself, they don't need a speaker. They need an intervention, because it needs to come from the top. The thinking needs to change at the top. And so then it'll trickle down so people feel comfortable saying, hey, I need a mental health break. I need to take care of myself. I've got kids at home. They're sick. I'm struggling with this. I'm struggling with that. I'm at my breaking point, and I really just need to take some time to take care of myself. I need to go see a therapist. And there are a lot of law firms I've dealt with that are truly changing their culture and coming up with these plans for people to take care of themselves. And so that's the good news. We just have to keep encouraging these law firms to do so. Now, another problem is, of course, if you're a solo practitioner, small law firm, you sometimes have problems with insurance. And so there are some people who will not spend the money because their money is already it's already dedicated to other things, and they think, well, the last thing I'm going to do is spend money on a therapist or a psychiatrist or PHP or IOP, and that takes up so much time, etc. The reasons for not doing it are monumental, but financial is one of the biggest ones. And so, and I may be preempting the conversation here, but there are scholarships that can, for solos and for small law firms, where people can apply to get a scholarship, especially through the Texas Lawyers Assistance Program, that can help with those therapeutic treatments.
And that's the Sharon Crowley Trust. That's
exactly right. The Sharon Crowley Trust is a state bar trust that has its own board of directors, but really is affiliated with the Texas Lawyers Assistance Program. And you can contact TLAP and apply for a scholarship. And I'm not going to go into the numbers how much will go to outpatient therapy or inpatient, but there is monies for both inpatient and for private therapy as well, if you can't afford it. And then there's an organization here in Dallas called the Professional Wellness Institute, and that if you're having trouble paying your rent, if you can't pay for your meds, you can apply for a scholarship through the Professional Wellness Institute and also get some relief.
And I'd love to talk a little bit more about some of the other resources. We talk about TLAP. It's almost not an ethics CLE if you don't talk about TLAP.
Yeah,
it's
right.
But what can TLAP do for someone who calls and says, I'm struggling with depression?
Okay, TLAP is is 100% confidential by statute. Okay, so if you call in and you need some help, but you're afraid it's going to get back to your law firm or you get back to your employer, whatever, it won't. It's confidential, and you can get the help through them and feel safe doing so. So it's for judges, law students, and attorneys. And it is a there's a referral element to TLAP as well, because what TLAP has done is TLAP has a list of providers and cities all over the state of Texas, okay? And they've been vetted. And so if you don't know where to turn and you don't have someone great like Kara that you just don't know about her or know about others, you can call TLAP and then they can refer you to treatment providers in your location, which is so powerful because I get calls all the time. Terry, I don't know where to turn. I don't know who to look, where to even find someone. And then of course there are online therapy programs as well. BetterHelp is an online therapy program. Kara, no?
No to BetterHelp. There are other options. I can help you find them, but no to BetterHelp. But
so
okay, good. This is good.
What's your perspective on BetterHelp, Kara?
Do you really? I don't know if we want to use this time to talk about on BetterHelp. Here's what I will say. Their policies do not keep clients' information confidential. So that is like the primary issue. And they don't pay clinicians. That is a personal issue. But for clients, it is the policies they have set up are not great. But I have additional resources that I can forward to you and Jay that y'all can pass around to your people.
Thanks for that. I mean, that's important information because we don't want to send people places and it just not work. It's not, it's not the good. So I don't know about that, but I'm going to take your word for it. But all I know is that if you do need some help with a provider, call TLAP. They'll provide you that. Then the third element is peer support. And studies show that the best way to deal with depression is with medication. Listen, I have no shame. I have to take Tylenol for a headache. I take medication because my brain does not make the chemicals that I need. So I have to have medication. Big deal. I'm not ashamed of that at all. Medication, cognitive behavioral therapy, and peer support. And peer support looks like groups in a law firm getting together where people can process what goes on in their practice, or lawyers concerned for lawyers. And there's a lawyers concerned for lawyers group all over the state of Texas. And if you want to find one, go to the TLAP website, tlaphelps.org. And there is a list of lawyers concerned for lawyers, and many of the meetings are online. So you can join in Houston, even if you're in Dallas, if you just get the right link, right? And then there's also the Monday night group here in Dallas, and I'm sure there are other groups in the state of Texas that is specifically a confidential group meeting of people who are struggling with their mental health or are in remission from depression, which I'm in remission from depression. I didn't even know I had depression until I knew I had depression. And then boom, I could treat it. And now I'm able to do the things that I want to in my life because I'm treating my depression and anxiety. So those are the three legs of the stool. And so if you want to know about peer support, there's a toolbox on the TLAP website that can give you lots and lots of suggestions.
In our last 10 minutes or so here, I'd love to turn the conversation now to, I hate the word intervention because I think the word intervention draws to mind like a room full of people, your parents telling you that they're disappointed in you because you did too much coke. I think, but the literal act of intervening, right? Like I identify that I have a friend or a colleague or a loved one who I think is at suicide risk, or who I think is maybe not at the point of being a suicide risk, but I have identified them as likely experiencing depression. Kara, what steps should I take if I see that someone around me is struggling?
I think the first thing to keep in mind is that when dealing with adults, there's not much you can make happen, right? Like, I cannot force you, Jay, to go seek help. Unfortunately, I cannot put you in the car and say we are going to do it. I can highly, highly encourage you to do that. But I think if we are talking about in that same severity scale, the highest severity of like, oh, you're going to act on this now, I have to do something now. And that might mean doing our least favorite thing, which is calling the police to do a wellness check. Now, the likelihood of that needing to happen is a little bit lower. A lot of the times, your biggest intervention is to ask. As Sherry has mentioned, right? Or Terry has mentioned. Sorry, I just saw Sherry's name, and so I got a little confused. As Terry has mentioned, all you have to do is ask, how are you doing? How are things going? What is it you're willing to do now? I think that's one of the biggest questions you can kind of ask someone else. It's like, what is it you're willing to do at this point? What can we do to kind of help you? One of the primary effective treatments of depression is a fun little term we call behavioral activation. What that essentially just means is finding areas in which you're changing your behaviors around your symptoms, right? And so one easy one to draw upon is like eating. You might find that you're not eating at all or not eating as much as you can. So there might be a willingness and conversation of like, how do I get you to eat just a little bit more? What if instead of skipping lunch and dinner, we at least try to eat dinner tonight? Can you go out with me to dinner tonight? Let me get you some food in you, right? And so behavioral activation is essentially engaging in behaviors opposite of what depression is having you do. So that might encourage you and start to change the way your brain is thinking about it. And so that's a really common one that I think even a lay person can kind of adopt, right? So you might see some of these symptoms in someone that you care about, and then you might be able to be like, hey, let's go grab something to eat. Or if you're kind of like rotting on the couch, which is a really common one that we find a lot of, and some of it's really good restful time, but some of it's not as much. Maybe it's let's go take a walk in the park for a little bit. Let's experience some time outside. And so that might be something you can do for someone who is depressed or someone who is kind of showing some of that withdrawal or showing some of that like turning away from other people.
And so you mentioned the, the most severe kind of active intervention is calling for a wellness check. Well, what is that? What is a wellness check?
It is, you reach out to, I think it's a non-emergency helpline unless you feel like it is an emergency, then you do reach out to 911. But there is a non-emergency helpline in your area for the most part, and that's going to differ for different people. So I don't have like each number for each area. But you can reach out and just say, hey, I have concerns about someone that I care about. They'll send out someone to do like a wellness check on that, on their behaviors or how they're feeling. And if it needs to escalate, then they will make that choice to escalate it.
Well, we've got a couple audience questions. Or Terry, it looked like you were going to chime in.
Yeah, no, I was gonna mention that too. Go ahead. Yeah.
Okay, we've got a couple of questions in from the audience. My favorite one here is not a question, just want to say this has been fantastic. So thank you for whoever submitted that one. It's very kind of you. I'm going to mark that one as answered. So the first question from our audience is, what are some of the signs you can identify within yourself to help you identify when you should reach out for help and when you must reach out for help? Terry, Kara, do y'all have any thoughts on that?
Well, I think Kara did a great job of kind of explaining that. But Kara, do you have any more that you could think of?
I think the biggest thing I would reiterate is feeling distressed, right? And so if this is uncomfortable, if you are not happy, if you are not satisfied, if there are things, then your thought pattern. So it's like if there's a lot of negative thinking, you even mentioned black and white thinking. If there's, and I think it's hard for us to like, for me to present this language if it's not like a shared language. So I am trying to kind of move it into more of a shared language, which at times makes it a bit more vague. And I recognize that. But if it is I think the biggest term for me is distressed. If you are distressed by the way things are going, there is not an inappropriate time to reach out for help. More than anything, like if it is uncomfortable and you're distressed, you're not going to be turned away from receiving help. Someone might guide you in an appropriate direction on what help could look like more effectively for you, but there is not an inappropriate time to seek help. I would say must help is if there is absolutely no hope and you can't see the future. Like if there's no grasp on what your future looks like, that is when I would say, please, please, please go talk to somebody. That is probably when I would say must. But any other time, do. Like if it is calling to you and you feel like, oh, I probably need to talk to someone, go do it. I think that is appropriate.
We've got another question in from the audience. When does wanting to recharge or getting too much rest become a sign of depression?
Let me just give you a personal experience on that. After my daughter died, I suffered my own depression, clearly. And what happens with depression, as far as what I have learned and what I've experienced, is that you just don't have energy, right? It saps your energy. And so what I would do is I would get my kids off to school and I would lay down on a couch with my dog on my chest, and I would read novel after novel after novel. I didn't answer the door. I isolated. I didn't want to talk to anyone because I was exhausted. It was like dragging a ball and chain all through my life. It was very difficult. And by the way, I felt depression physically. I felt it. It was like a vice on my head, and I could feel it in my temples. And it was like someone was squeezing that vice. I could feel depression. And so now I know if I'm just exhausted from my job, I'm tired, I need to recharge, I need to take a long weekend, I know that I'm going to feel better once I do that, compared to I feel like I'm dragging a ball in a chain, I'm exhausted, I want to sleep all day long, I can't get out of bed, I know the difference. And so if you can't recharge after a period of time away from your job and away from maybe vacation, then think about maybe you do need to go see someone and be diagnosed. At least just get a diagnosis. Maybe they'll say, oh, you're fine, you just worked too long, or you've had a busy week, or that trial just wiped you out, or you might need some help.
Yeah. The word that comes to mind for answering this question is the difference between intentionality and just doing. Rest and recharge, we usually find to be very intentional. And so if you are engaging, like going on a vacation, or, taking in something that you find to be very enjoyable, if that's intentional, you're probably resting and recharging. But if you are just doing it to waste time, or if you're just doing it to kind of wait until you can go to bed, then you're probably not getting that rest and recharge that you're looking for. And that might be a sign of something else.
Well, Kara, Terry, thank you so much. Before we go, I want to share a comment we just got in from the audience. Watching a DAYL Wellness CLE helped encourage me to find a therapist and get help. Thank you all for your time today. That's exactly why we do this. And I know that your time is very valuable. I cannot tell you how much we appreciate you sharing it with us. So for our attendees here today, if you'll please look in the chat, you'll see that Miss Sherry Harris, our executive director, has posted today's course number. You'll self-report your CLE attendance, so make sure that you get that down before you go. And thank you just again. We got one last Q&A. Oh no, that's me not knowing how to work Zoom. What a great way to end the presentation. So again, Kara, Terry, thank you so much for making time to discuss this incredibly, incredibly important topic. And thank you to our attendees for making time to listen. Genuinely, these conversations can't happen enough, because that's how we end the stigma. So thank you.
Yeah, Jay, thank you. Thank you for addressing it. It's so important. Wonderful job. Thank you.
Thank you.
Thank you. And thank you for having me.
Thank you all for being here. All right. And on that note, we will call this a wrap. Y'all have a great day.
You too. Bye-bye, everybody.